Hello everyone and welcome to our module on diuretics. Diuretics are drugs that increase urine output, and shown on this slide are the 5 classes of diuretic drugs. These first 3 are often used to increase the urine output in patients so that they will have a clinical benefit. The last 2 types of diuretics, carbonic anhydrase inhibitors and osmotic diuretics, these drugs are never used to increase the urine output. They just happen to have that effect. As we'll see later, they are used for other reasons, and the fact that they increase the urine output is just sort of an additional effect. Before we talk about specific diuretics, let me briefly talk about how sodium is handled by the kidneys. So the normal plasma sodium concentration, as you may know, is 140 milliequivalents per liter. And this concentration is tightly regulated by the renin-angiotensin-aldosterone system and by antidiuretic hormone, or ADH. So what this means is anytime you take in some sodium in your diet, your kidneys retain water so that the plasma sodium remains 140. In addition, if you ever lose sodium for any reason, your kidneys will excrete water so that the sodium concentration remains 140. And so this is how most diuretics work. They increase the sodium excretion by the kidneys, and that will always be accompanied by water excretion, and therefore that will increase the urine output. So many diuretics work by increasing the sodium excretion by the kidneys. This always leads to water excretion and therefore an increase in urine output. In addition to affecting sodium, many diuretics affect potassium balance. Potassium is secreted into the urine by this portion of the nephron here, the distal tubule and collecting duct. And the amount of potassium that gets put into the urine varies with the flow of urine through the nephron. So anytime you increase flow through this nephron, more potassium will go out into the urine. So therefore, many drugs that are diuretics, which will increase urine volume, are also going to lead to hypokalemia. They're going to increase the urine volume flowing through the nephron. That's going to cause more potassium to be secreted, and therefore that can lead to hypokalemia, a common side effect of diuretics. First group of diuretics we're going to talk about are the loop diuretics, and they're called loop diuretics because they inhibit the sodium-potassium 2-chloride pump in the loop of Henle, specifically in the thick ascending limb. In this slide, I've zoomed in on a tubular epithelial cell from the thick ascending limb so we can see exactly what the sodium-potassium 2-chloride pump does. So here we've got the lumen of the nephron where the urine is, and over here is the interstitium or blood. So the pump that's inhibited by loop diuretics removes sodium, potassium, and 2-chloride ions. However, the potassium ion that is pulled from the urine immediately goes back to the urine through a channel. What this means is the overall effect of this pump is to remove 1 positively charged ion, sodium, and 2 negatively charged chloride ions. Because you've removed more negative ions than positive ions, you're going to leave behind a net positive charge in the urine, and that's the effect of this pump, to generate a net positive charge in the urine. That positive charge will drive the positively charged ions, magnesium and calcium, to be reabsorbed via the paracellular route. So what this means is if you inhibit the activity of this pump, more sodium will stay on this side of the cell in the urine, and when more sodium goes out in the urine, it takes water with it, as we have discussed, so therefore these drugs are going to work as diuretics and remove sodium and water from the body. In addition, magnesium and calcium are not going to get reabsorbed because you've inhibited that pump, so you will lose magnesium and calcium in the urine. And then finally, loop diuretics have no effect on potassium here because the potassium that's reabsorbed just goes out in the urine. However, anytime the amount of sodium and water going out in the urine increases, as we talked about before, that leads to more potassium secretion in the collecting duct, and therefore loop diuretics will also increase the potassium that is excreted in the urine. So the important loop diuretics are furosemide, bumetanide, torsemide, and ethacrynic acid. And these drugs inhibit the sodium-potassium 2-chloride pump just like we discussed on the last slide. This will lead to more sodium excretion, and that will take water with it, and therefore urine output will go up. This will increase magnesium and calcium excretion for the reasons we just talked about. And like all diuretics that increase the flow through the nephron, this will increase potassium excretion. This pump here is very important for controlling the amount of water that is reabsorbed by the kidneys. So when you inhibit it, the kidneys really lose their ability to reabsorb water, and therefore these drugs have a strong diuretic effect. They produce a vigorous increase in urine output, and therefore they're used for edematous states like heart failure and cirrhosis, where patients have lots of extra volume on the body that you want to get out. These drugs will produce a large increase in urine output. The side effects of these drugs are very easy to remember if you understand how loop diuretics work. So they can cause hypokalemia, as we just discussed. They can also cause hypocalcemia and hypomagnesemia because they block the reabsorption of those substances as well. They decrease the volume circulating through the body, so this will cause a contraction alkalosis with a rise in the serum bicarbonate. And in the video on metabolic alkalosis, I explain how diuretics and anything that decreases the circulating volume can cause a contraction alkalosis. Most of the loop diuretics are sulfa drugs. For example, furosemide you can see as a sulfa moiety right here. So all of them potentially can cause an allergy in sulfa allergic patients. The one exception is ethacrynic acid. Ethacrynic acid is not a sulfa drug, and it's the one loop diuretic safe to use in patients with a sulfa allergy. Some other side effects are shown in this slide. Ototoxicity can occur when patients receive very, very high dosages of loop diuretics, or if they receive a loop diuretic together with another drug that is ototoxic, for example, an aminoglycoside antibiotic. These patients will develop tinnitus and loss of hearing, and this is usually reversible when you stop the drug. The loop diuretics that are sulfa drugs can cause acute interstitial nephritis, which I talk about in the video on tubulointerstitial disorders. This presents with a rise in the BUN and creatinine, white blood cell casts in the urine, and urine eosinophils. And then finally, loop diuretics are famous for increasing the serum uric acid level, and this can precipitate an episode of gout. Uric acid has a complex mechanism by which it's handled by the kidneys, and all you really need to know about this is that both thiazides and loop diuretics cause more uric acid to be reabsorbed from the nephron. This means that they can potentially promote an episode of gout. So this is a patient on the screen with a swollen big toe. It's a classic symptom of gout. And many patients on diuretics, especially thiazides and loops, develop gout, and that's because the amount of uric acid reabsorption goes up when patients take diuretics. Our next class of diuretics are the thiazide diuretics. These drugs work on the distal convoluted tubule, as shown in this picture here, and they inhibit sodium and chloride reabsorption in this section of the nephron. So as we have discussed, that will send more sodium out in the urine, and it will take water with it, and that will increase the urine output. Thiazide diuretics also promote the reabsorption of calcium from the urine, and therefore they can potentially cause hypercalcemia. This happens because when you inhibit the function of this pump, less sodium is pulled from the urine, and therefore there's a decrease in the amount of intracellular sodium. That will cause this sodium-calcium exchanger to become more active. It will bring more sodium into the cell and push more calcium out of the cell. That will increase the overall reabsorption of calcium from the urine, and therefore you see calcium levels in the urine go down and calcium levels in the blood can go up. There are many thiazide diuretics. Some of the commonly used drugs are hydrochlorothiazide, chlorthalidone, and metolazone. I've shown their structures on the screen here. Technically, to be a thiazide diuretic, you need to have a ring with a sulfur in it like this. Metolazone and chlorthalidone do not have a ring like that, therefore they are called thiazide-like diuretics. They have the same effect, but their chemical compound is technically not a thiazide. Most of these drugs are sulfa drugs, so patients with a sulfa allergy can develop an allergic reaction. You can see there's a sulfa moiety in all of these drugs shown on the screen here. Thiazide diuretics can increase the level of glucose and lipids very modestly. At the dosages we use in modern practice, these effects are very, very mild and usually not clinically relevant. Years ago, when much higher dosages of thiazides were used, patients could develop significant increases in glucose and lipids from these drugs. We've already talked about how thiazides can increase uric acid levels, and we've also already talked about how they increase calcium levels. And many people remember this collection of effects of thiazide drugs by the mnemonic hypergluc. Thiazide drugs are famous for causing hyponatremia. Now, any diuretic can potentially cause hyponatremia, but thiazides do it more commonly than any other drug. The reason for this is because they cause mild volume depletion, which activates the renin-angiotensin-aldosterone system, and that causes levels of ADH to rise. When ADH is high, patients who drink water will hold on to that water, and that can cause hyponatremia. Now, this can happen with any diuretic because all diuretics that cause volume depletion raise the level of ADH. However, with thiazide diuretics, the ability of the kidneys to retain water remains intact and very strong, and therefore these drugs raise the level of ADH and they allow the kidneys to easily hold on to lots of water, and that's a setup for developing hyponatremia. These drugs also cause hypokalemia because, as we talked about before, drugs that increase flow through the nephron can always cause hypokalemia. And then finally, these drugs can cause a contraction alkalosis, just like we talked about with loop diuretics. Shown on this slide are some of the clinical uses of thiazide diuretics. First of all, these drugs are commonly used for hypertension. They cause a mild diuresis, and therefore they lower the blood pressure. They can be used in patients who have recurrent calcium kidney stones because, as we have already discussed, they pull calcium from the urine and reduce the urinary calcium, and this makes it less likely that a calcium stone will form. They can also be used in patients with osteoporosis. That's because they increase the serum calcium, which is good for bone health. And then finally, thiazide diuretics can be used in diabetes insipidus. I talk about diabetes insipidus in the video on sodium disorders, but by way of review, it's a condition in which the nephron does not respond normally to ADH. As a result, patients make lots of urine and they complain of polyuria and polydipsia. Now, it might seem crazy that you would give a diuretic to a patient who has polyuria, but let me explain why this can help. In patients with diabetes insipidus, they cannot pull water from the collecting duct normally, and that's because they are not responding to ADH. If you give a thiazide diuretic, this causes some sodium to go out in the urine, and that lowers the effective circulating volume inside the vasculature. Anytime the ECV gets low, this activates the sympathetic nervous system and the renin-angiotensin-aldosterone system. And one of the effects of those two systems is for more sodium and water to be reabsorbed from the proximal tubule. What this means is in patients with diabetes insipidus who cannot reabsorb water from this part of the nephron, by giving a thiazide diuretic, you help them to pull water from this part of the nephron. This increases water reabsorption and it helps to decrease the amount of polyuria that these patients have. So counterintuitively, patients who have DI have an anti-diuretic effect when you give a thiazide diuretic, and that's because more water ends up getting reabsorbed from the proximal tubule. Our next group of diuretics are the potassium-sparing diuretics. There are two types of potassium-sparing diuretics. Spironolactone and eplerenone block the aldosterone receptor site. Triamterene and amiloride block the aldosterone sodium channel. Both interfere with the reabsorption of sodium, but via a different mechanism. As I told you before, most diuretics cause the potassium level to fall. That's because they increase flow of urine through the nephron. Potassium-sparing diuretics are unique. Because of the channel that they block, they actually raise the potassium level in the serum. And because they don't cause potassium to fall, that's why they get the name potassium-sparing diuretics. These drugs are a great choice in patients who have hypokalemia. So for example, heart failure patients on loop diuretics frequently develop hypokalemia. If you add a potassium-sparing diuretic to their regimen, that will boost the potassium level and potentially resolve the hypokalemia. And then finally, these drugs have been shown to reduce mortality from systolic heart failure, and I talk about this in more detail in the cardiology videos on heart failure. So let's talk about how potassium-sparing diuretics work. These drugs act on cells in the collecting duct of the nephron. And in the collecting duct, there are two important types of cells. One type is called the principal cell. The other type is called the intercalated cell. Aldosterone acts on a sodium channel in the principal cells to promote the reabsorption of sodium. Therefore, if you block the effects of aldosterone, or if you inhibit this sodium channel, both of these actions will have the same effect. There'll be more sodium here in the urine, there'll be less sodium reabsorbed, and when there's more sodium in the urine, that will take water with it and increase the urine output and have a diuretic effect. Now, when sodium leaves the urine because of the effects of aldosterone in this channel, that leaves behind a negative charge in the urine because you're pulling a positively charged molecule out of the urine. That negative charge will draw in potassium, which is positively charged. So what this means is when you block the effects of aldosterone or block this channel, less potassium is pulled into the urine, and therefore you get an increase in the potassium level in the blood. And that's why these drugs can cause hyperkalemia, and that's why they're called potassium-sparing diuretics, because they do not decrease the serum potassium level. So here's a summary of the key effects of potassium-sparing diuretics. All of them increase sodium and water excretion because they are all diuretics. They all spare potassium, meaning unlike other diuretics, they do not increase potassium excretion, and therefore hyperkalemia is a side effect of these drugs, as opposed to most other diuretics where hypokalemia is a side effect. A special note about spironolactone, it has a similar structure to testosterone. If you look at the bottom of the screen, this is the structure of spironolactone. It's got a steroid structure very similar to testosterone. This means that when you give spironolactone to men, you will block testosterone effects, and men could potentially develop gynecomastia. This is a picture of a man with gynecomastia here. That's what can happen to men who take spironolactone. Eplerenone is the other potassium-sparing diuretic besides spironolactone that inhibits aldosterone effects, and the claim to fame of eplerenone is that it's been shown to not cause gynecomastia. So in men taking spironolactone who develop gynecomastia, you can switch them to eplerenone and they should not get this side effect. In addition to having a similar structure to testosterone, spironolactone is similar to progesterone, and therefore if you give it to women, it activates progesterone receptors, and this can cause amenorrhea if you give this to women who are of childbearing age and still having menstrual periods. A brief word about renal failure. All diuretics can cause renal failure. That's because they all cause volume loss, and therefore they decrease the effective circulating volume, and that lowers the GFR. So in any patient on a loop or a thiazide diuretic, you can see a rise in the BUN and the creatinine, and this is an expected effect of these drugs because you have decreased the effective circulating volume. Back to this slide, we've now talked about loop, thiazide, and potassium-sparing diuretics, and these three classes of drugs are really what people mean when they say we're giving someone a diuretic, and by that I mean that these drugs are used to promote urine output. I'll finish this video by talking about carbonic anhydrase inhibitors and osmotic diuretics. Drugs in these classes are never used to increase the urine output. They do have that effect, but that's not the reason we use them clinically, as we will see in the next few slides. Carbonic anhydrase is an enzyme found in the proximal tubule, and so lots of bicarbonate and sodium gets filtered into the nephron, and it's reabsorbed by the proximal tubule. And you need the enzyme carbonic anhydrase to reabsorb bicarbonate and sodium. So if you inhibit this enzyme with a drug, that will cause bicarbonate and sodium to go out in the urine, and any drug that causes sodium to go out in the urine has a diuretic effect. So technically, carbonic anhydrase inhibitors are diuretics. The diuretic effect of these drugs is very weak, and therefore they are never used to promote urine output. Instead, what they are used to do is to get bicarbonate out of the body in situations where that can be beneficial. There's really only one important carbonic anhydrase inhibitor that's used clinically, and that's the drug acetazolamide. As I just said, it has a weak diuretic effect because it blocks some sodium reabsorption, but really its main impact on the body is that it causes bicarbonate to go out in the urine. This leads to a non-anion gap metabolic acidosis. This is all from blocking the reabsorption of bicarbonate in the proximal tubule and increasing the elimination of bicarbonate from the body. So carbonic anhydrase inhibitors like acetazolamide are used in a couple of niche circumstances. The first one is in patients who have a severe metabolic alkalosis. In these cases, the pH is very, very high, and by giving acetazolamide, you will cause bicarbonate to go out in the urine, and that will decrease the pH. Another place where they're used is in glaucoma. That's because the enzyme carbonic anhydrase is important for the formation of aqueous humor, and therefore when you give a drug to a patient with glaucoma, less aqueous humor is produced. This has nothing to do with the effects of carbonic anhydrase inhibitors on the kidneys. Pseudotumor cerebri is a condition in which there's increased intracranial pressure, and I talk about this in videos in the neurology section. But in this condition, you can use acetazolamide because carbonic anhydrase is important for formation of cerebral spinal fluid. So by inhibiting carbonic anhydrase, you reduce the rate of CSF formation, and this will lower the intracranial pressure. And then finally, carbonic anhydrase inhibitors like acetazolamide are helpful for prevention of high altitude sickness. So when you ascend to high altitude, there's a very low PO2 at high altitude because atmospheric pressure is so low. This causes the body to hyperventilate in order to maintain oxygenation. When you hyperventilate, you blow off CO2 and the arterial CO2 level becomes low. This causes a respiratory alkalosis. And in a respiratory alkalosis, the pH will be high. If you give patients ascending to high altitude acetazolamide, they will excrete bicarbonate in the urine. This will cause an acidosis, and this reverses the alkalosis, which has been shown to limit some of the symptoms like headache and other symptoms that patients can develop when they ascend to high altitude. Some of the side effects of acetazolamide are shown in this slide. First of all, it causes a metabolic acidosis. This isn't really a side effect. This is what the drug is supposed to do, but you need to be aware of this in any patient you're treating with acetazolamide. It can cause paresthesias. Some patients complain of tingling in their extremities. And then finally, acetazolamide is a sulfa drug, as you can see here, so it can potentially cause an allergic reaction in a patient with a sulfa allergy. Carbonic anhydrase inhibitors like acetazolamide can cause kidney stones. The reason for this is when you decrease the reabsorption of bicarbonate, you reduce the excretion of citrate in the urine. Citrate is shown on the screen here, and citrate in the urine is very helpful because it inhibits formation of calcium stones. So when you give a patient acetazolamide, there will be less citrate in the urine, and that sets them up to get a calcium kidney stone. Our last group of diuretics are the osmotic diuretics, and there's really only one important drug in this class, and that's mannitol. Mannitol is a sugar alcohol that's freely filtered by the glomerulus, and it's not reabsorbed by the tubule. What this means is it's going to find its way into the lumen of the nephron, and it's going to stay there, and it's a very osmotically active substance, so it's going to raise the osmolarity of the urine in the nephron. When you raise the osmolarity of urine in the nephron here, less water gets reabsorbed in the thin descending limb. Therefore, this drug will reduce water reabsorption and increase the urine output, and that makes it a diuretic. Although, as I said before, we never use this drug for its diuretic properties, we always use it for other reasons. So the main two times when we use mannitol is in cerebral edema or in glaucoma. The idea here is to create a hyperosmolar state in the vasculature, not in the kidney. This is called osmotherapy. So if you increase the osmolarity of plasma by putting mannitol in the plasma, that will draw lots of water out of other places. Basically, you'll dry out the body and pull all that water into the plasma, and from there it will go to the kidneys and out in the urine. So by drawing fluid out of the brain, this is helpful in patients who have cerebral edema, like this person whose MRI is shown on the screen here. It also helps to draw fluid out of the eye in patients with glaucoma, because that will lower the intraocular pressure. So these are the circumstances where we use mannitol. It's not because of its diuretic properties, it's because we want to raise the osmolarity of plasma. Two things you want to know about mannitol are that you can't use it in patients with heart failure and you can't use it in patients with severe renal disease. As I just told you, it draws fluid out of tissues and expands the intravascular volume, and this is a horrible idea in someone who has heart failure. Patients with heart failure have high pressures in the chambers of their heart. They have high left atrial pressure, which causes pulmonary edema. So if you give them mannitol, you will fill the vasculature with fluid, and that will cause severe pulmonary edema. So you can never give mannitol to patients who have heart failure. You also can't give it to patients with severe renal disease. The reason for this is that at high dosages, it can shut down the kidneys so they stop making urine. This is called anuric renal failure. This is believed to occur because mannitol can cause renal vasoconstriction, and that shuts off blood flow to the kidneys and leads to anuria. So mannitol is basically only a drug for patients who have normal hearts and normal kidneys. It's not given to patients with heart failure and severe renal disease. And that concludes our video on diuretics.